Hello everyone, we're going to be doing a fun little stream. I want you to ask me your health question. And a lot of you said mental health, nutrition, here we go. That's a great question, Alaya. So colds are typically caused by viruses. And viruses, kind of like the COVID virus, there are so many viruses. They're constantly mutating. When you have a viral infection, and a cold specifically, it's typically caused by a virus called rhinovirus. Do you have an animal stuck in you? Most likely not. The rhinovirus is called rhinovirus because rhinos, think of their horns, affect the upper airway. So when we think about infections, we kind of divide them into two different kinds of infections: upper respiratory infections and lower respiratory infections. So when your doctor goes and listens to you when you are sick, they're looking to hear if your lungs have any additional sounds, any crackles, which think of like Rice Krispies, that kind of when you pour that delicious milk on Rice Krispies. Oh, when they listen to your lungs, they're looking to see if you're wheezing, if you have any crackles, any rails, rubs, any additional sounds in your lungs that might sound like it's infected. The way to treat colds and viral infections is, you ready? We do what's called supportive care. Supportive care is essentially telling you to manage your symptoms. So if you have a fever, if you have a cough, if you have a headache, use medicines or herbal remedies to treat those symptoms. What we typically say, especially for kids, is it takes 3 days to get infected, 3 days to be infected, and about 3 days to get over being infected. So about 7 to 10 days of a viral course in your body. So we get this question a lot. Oh, my children just hung out at a party today and now they're sick. Likely not from that party, because the virus needs some time to incubate and to replicate in your system before it can cause an effect. And your immune system does a good job at learning from these viral infections so that the next time you are presented with an antigen, which is just like a small little piece of a pathogen, which is just a fancy word for a germ. The next time your body sees a little piece of a germ, it's like, oh, you, I seen you. You caused problems before. What are you doing up in here? Oh, and they go and like take care of it. Hopefully. But if you did have a bacterial infection, then we would give antibiotics. Oh, that was a lot for just one question, but I hope it helped. This is also a really great question. So eczema, I need another bite. Y'all don't keep me up. It's like I'm working overtime tonight. Think of eczema as your body reacting to something, either fabrics or soaps, certain foods, and the way that your body reacts to that allergen, that thing that might cause you to have an inflammation of your skin. The way your body makes eczema, it uses the same ingredients to make asthma, and it uses the same ingredients to make allergies. So we actually call it the atopic triad. So when a child comes in and they have eczema, we then ask the family, does anyone else have asthma or allergies? Because you can use, and I made a video about this, the asthma predictive index, which is when kids are so little that they can't do the test that we do to diagnose asthma, which is they could do by like 5 or 6 years old. I didn't actually try the test, but I saw kids trying the test. They have a screen with candles on it, and the tech tells them to blow really hard as if they're trying to blow out all the candles. Imagine a 3-year-old trying to do that. They're just gonna get spit everywhere. But a 6-year-old can comprehend to like put a tube in their mouth and go really fast. So that's the test that we use to diagnose asthma. But little kids can't do that, but does that mean they can't get diagnosed with asthma? If you ask a different pediatrician, they give you different answers. But what we use is the asthma predictive index, which asks the family about genetic questions like, does the family have any history of eczema, of allergies, of asthma? Because then the child can have an increased risk. So if you want, you can go check that video. Interesting. Let me walk through some things that might be more red flags if I met you in the emergency room. And again, this is just for your own education. Please talk to your own doctor. When you eat these foods, I know you say your stomach hurts. Do you ever have symptoms like diarrhea, constipation? And then if you do, in your stool, do you ever have blood? That would be a more warning sign that the cell lining of your intestines are starting to slough, which is a fancy word for just slide off. Slide off? Slough? What? Is that where the word comes from? Slide off, slough? Yo. That's amazing. If you go Google and type in and make sure you come back because I'd love to have you come back and keep me company. BRISTOL, Bristol Stool Chart. So look at the Bristol Stool Chart. It'll tell you different grades of stool from grade 1 through 7, and it'll let you know which one is most akin to constipation, which stool types are normal, and which stool types are diarrhea. Oh, that's a really great question. I take care of a lot of kids with sickle cell, and what we do for chronic pain is an escalating titration of a medication regimen. So you would have for mild pain, like Tylenol, for moderate pain, Motrin, and then for like severe pain, an oxycodone. When they're in the hospital, we kind of do that as an IV version. So you do Tylenol for mild, you do Toradol, which is just IV Motrin, and then IV morphine for severe. Some people who have sickle cell, the morphine doesn't work for them, so you can exchange it for like a Dilaudid, and you just have to be mindful that those medicines cause respiratory depression. If you are familiar with the whole epidemic that happened with opioids, it's still happening, that people take it and overdose, and what it does is it depresses your system so you're no longer able to breathe and you stop breathing. And it also slows your system down so much that while you're taking it, we usually start people on Miralax, which is just some bowel softener, and it helps you continue to poop even though your intestines are slowing down because of the medication. I learned pain is the 5th vital sign. 5th? Blood pressure, heart rate, respiratory rate, oxygen saturation. Oh, 6th vital sign. Yes, thank you. I'm missing something. So I think it's important. It's very important because pain is subjective, what the patient tells you. So if a baby or a kid is like, oh, my belly hurts, you're like, okay. Then you go do your exam. And tenderness is if you elicit a wince or a response of pain on your exam. So for kids, we actually have to be a little bit smart, because if you listen to their belly and you say, okay, now I'm gonna press on your belly, and you press, then they're gonna go, owie, and you can't really tell if they're telling the truth or not. So what you do is you say, I'm gonna listen to your belly now. And you take the stethoscope and you press as deep, and you start listening while also trying to elicit pain, and you start looking and you say, okay, now I'm gonna press. And then when you press, they go, ow, and you're like, okay, you little liar. You little liar. So that's just a little trick that we've had to come up with in pediatrics. Pediatrics does not get enough credit for all that we do. Because I was just thinking about it today in the NICU. I have babies who are screaming, wriggling, breathing at 100 breaths a minute. Their heartbeat is at 200. And I have to listen in and try to discern breath sounds from heart sounds, from cry sounds, from belly sounds. And I'm like, you can't tell them, please stop. I mean, you can't. But they're not going to. Versus an adult, it's just take a deep breath. Thank you so much. Babies, take a deep breath. I can understand how if you are someone who is really experiencing pain and it's not adequately treated, and you don't feel seen and heard, and it's not adequately managed, that would create distrust in the medical system or in your provider. However, please, I think this is a great place to have a conversation back and forth that on the provider perspective, you don't want to enable someone who actually does have a condition that they need support in and they might not want actual treatment for. So how do you navigate figuring out who wants it for pain and who wants it for a dependency? That's really hard. So I think ultimately people want what's best for everyone. We have to be like Sherlock Holmes sometimes. What happens when you're pregnant is you literally have a beautiful baby inside of you who is taking up space. So as they take up space, think about it. Where are they gonna go? Everything else gets pushed around. So your lungs get pushed, your bladder gets pushed. So you might not be able to feel like you can take as deep a breath. You might not be able to feel as though you can retain your urine as well. That's why when you sneeze or cough, you have stress incontinence where you kind of just increase intra-abdominal pressure, and the baby's already there saying, ooh, I already did that. So the bladder's like, I have no way to hold myself, and you get a little leakage, which is normal because you have a beautiful baby that you are bringing into this world. Making sure the kid is safe during a seizure. So first thing you should do is really just turn on a timer, because it's helpful to know how long the seizure lasted for, and also for you to have something objective to go based off of, because it's going to feel like a year. Every seizure is the most frightening thing ever. They're standing, we can ensure that they bring them down to either the floor or someplace where they're not going to fall, that you turn them on their side, so if they vomit, that doesn't go into their lungs, they can't potentially swallow it. And then, of course, to have medicine nearby.